patient care must come first, right? And how many do we have in attendance? I can't really tell.
We have 78.
All right, excellent. So I'm assuming this is Sadie I'm speaking with, yes?
Yes, it is me.
Okay, very good. Would you mind just keeping an eye on the comments section for questions as they may pop up? I just want everybody to know that comments are welcome, questions are welcome. I do not need to get through all these slides. This is just kind of an outline for discussion. You can absolutely make this as interactive as is desired. Sound good?
Sounds great.
All right, excellent. Let's see how to advance the slide. Here we go. All right. So I'm Jordan Roberts. I'm a family medicine physician here in Salt Lake with Granger Medical. I'm originally from Arizona, where I did my medical school training in Phoenix at the University of Arizona, and then came up to St. Mark's Hospital for my 3-year family medicine residency, and just fell in love with Salt Lake. So we decided to become permanent Utahns. This topic is near and dear to my heart. I'm a strong believer in the role of preventative health, and see my role as a physician as multifaceted. I consider myself a healer, an advocate, scientist, and hopefully a compassionate friend and resource to my patients and the public. So I base this off of a couple of different creeds. Most people have heard of the Hippocratic Oath, which is an oath that most medical students take in some form upon entering medical school or graduation. I personally prefer the Oath of Maimonides, who was a medieval Jewish physician practicing in Spain. I believe he was also the personal physician of the Sultan of Cairo. Interesting guy, fascinating life, and I think that his oath is even better than the Oath of Hippocrates. And my favorite line from his oath is this one: "May I never see in the patient anything but a fellow creature in pain." I used to have that hanging up on my wall. I just don't have enough space now.
1 second.
So let's talk about prevention. The idea of preventative medicine is an old idea. The proverb, prevention is better than cure, goes back to ancient Greek goddess of hygiene, where we get the word hygiene, hygia. And then more recently, an ounce of prevention is worth a pound of cure, attributed to Ben Franklin. Some interesting plus there. And here's some modern wisdom, which takes different forms, usually a little humorous. We call the meme. Only I had checked myself, says the dude who wrecked himself. Or this one. I'm sure this is nothing serious. It's probably just a cold. Me to me. Let's see what MD thinks.
Dr. Roberts, are you able to be closer to your microphone? It's a little quiet.
Oh yeah. Let me get a little closer. Thanks for the feedback. How's that? Any better?
A little bit better, still a little muffled.
Okay. Let me rearrange my screen here. Okay. How about now?
I think it's a little bit clearer on my end.
Okay. Well, I apologize for that.
Is the microphone on your computer all the way out? Sometimes that helps better.
Ooh, that's a good question. I'm not even sure how I would know.
There's like a little, mine has a little speaker on the bottom right of the screen.
Yeah. Sorry, I'm not sure, but I will try to lean in and just enunciate as clearly as possible. Let's go back to the presentation here. So I briefly want to talk about the different levels of prevention. So most people have heard of like an annual checkup or a physical, some people call it that. This is a visit that's strictly dedicated to preventative health, and most modern insurance companies will pay for a visit like this with your physician once a year with no out-of-pocket cost to you. So in theory, that would be a $0 copay. However, the amount billed to insurance can vary, but I'd say on average that that visit is reimbursed at about $150, once a year to go in and just get a checkup, make sure that you're not falling behind on the important screenings or vaccines or other preventative health topics. Now compare that to a regular office visit or a trip to the urgent care, for an injury or an illness, where typically they have some laboratory or other exam costs associated with that. That one of those visits will put you out, or your insurance company, between $200 and $300 on average, with a $20 to $50 copay. Now you compare that to an emergency room visit, and let's really play this up. Let's say it's a worst case scenario, right, where you had to go, by ambulance. You had to have the $1 million workup, lots of tests and pictures taken and treatments given. You're quickly looking at a very expensive encounter with the medical system, between $1,000 and sometimes as high as $5,000. But your out-of-pocket cost for that visit, if you don't have a high deductible plan where you have to pay everything up until you meet your deductible, could be as much as $100 to $200. And now let's talk about an admission to the hospital, with or without a stay in the ICU or a surgery. The average length of a hospital stay in America is between 4 and 5 days. Usually blood tests are drawn daily, specialists are consulted, there are specialist services like therapy that are provided, and medications, which we all know are more expensive in the hospital than on the outpatient side of things. And these are very expensive, can often be bankrupting for people if they don't have insurance or if they're underinsured. So these are very different types of encounters with the medical system. And you can see that prevention, which is kind of up here at the top, is dirt cheap compared to damage control, which is usually what the rest of medicine is. So let's talk about prevention. In my estimation, there are 3 different layers of prevention. The first is what we call primary prevention. So that's stopping something before it happens. A good example, a very common method of primary prevention is vaccination. And I actually have a whole nother lecture about the public and personal benefits of vaccines. I would love to give at some point if there's enough demand for that. But other primary preventative strategies would be like public health and safety things like water treatment facilities, food and drug safety, and counseling. Making sure that teens don't get into bad habits like smoking, drinking, STD prevention, these kinds of things. Preventing crime and illness before it starts. And then we have secondary prevention. So this is what screenings are. So a screening is different than a test. A test is usually performed when a person has symptoms for an illness, and you're trying to get a diagnosis for those symptoms. A screening is when a person has no symptoms, but they are at risk potentially for something like breast cancer, colon cancer, prostate cancer. And so you do this test to find that disease early, because there's a benefit to finding that thing early and getting it treated before waiting for the symptoms to arrive. And so typically in an office, like a preventative care visit, like a physical or an annual, we would focus primarily on primary and secondary preventative services. Tertiary prevention is, this person already has an issue, they have symptoms, and you're trying to prevent that issue from getting worse. So this is traditional medical care, is considered tertiary prevention. You're trying to prevent a person from dying early or prematurely because of their diabetes or because of their heart disease. Any questions about these different levels of prevention? Is this the first time that people have heard of this kind of stratification? If none,
Dr. Roberts,
yes.
speaking of preventative exams, it is Men's Health Month, and men are typically less likely to get a preventative exam than women. And I'm wondering if you have any tips or tricks to get more men to get their physicals or colonoscopies.
That is a very good point. I can't tell you how many preventative health visits I have with men who come in, and I ask them, like, so what brings you into my office today? Which is very, general way to kind of break the ice. can't tell you how many of those men then tell me, I don't know, my wife made the appointment. I'm just here because she made me come. So I mean, having a spouse that cares about you and pushes you to do the right thing, that's important, but not all of us are that lucky. So a lot of people wonder, like, when's the right time to come in? I'm 35, I'm 40, I haven't seen a doctor in 5 years, 10 years. Is this the right time? Do I wait till I'm 50? Um, my answer is it's never a bad time to go in and just have a checkup and talk about prevention. I see, just today, I saw 2 people in their mid-20s who had not seen a doctor since they graduated from the pediatrics office. But occasionally I'll see men in their 30s or 40s who tell me they haven't been to see a doctor in many years. And that's okay. You're not terribly behind the 8 ball. But whenever you think about it, if if you realize it's been a while and you might be overdue for some things like a tetanus booster or something like that, take that opportunity to come in and establish care with a primary doctor. We're not going to make you come more often than we really feel is necessary. And there's always important counseling topics we can discuss. But of course, as we get older, there are more things we need to focus on. And I'd say a big inflection point is when a person turns 40. That's a big, a big year, and definitely deserves a trip to just have a checkup. I saw a comment pop up. I'm not sure how to read it. Would you read that off for me, Sadie?
Yes, it says, my boyfriend just said that insurance companies should have men's health be a category when searching for a doctor. The website is very frustrating to me.
Yeah, no, I agree. Because, oftentimes we do see people who put on their website, we specialize in women's health. And I think that that's very appropriate. I have many patients who do prefer to see a female provider, especially if they need like a breast or pelvic exam. And I completely understand that. And I can see where some men would want to have maybe a male provider if they did have a concern about their sex life or about their genitals or something like that, and they would feel more comfortable with a man or a male provider or somebody who has some extra training in men's health. But yeah, it is not something you typically see advertised on websites or on insurance panels as much. But I'll tell you that any family doctor or any primary care provider will be almost certainly more than qualified to take care of a man's health needs, be they what they may. So thank you for that comment. So move on here. So my point here with this part is, this preventative strategy, you see things going from health to disease to suffering to death, right? And we want to catch people when they're still healthy, kind of keep them that way. Let's talk about the burden of disease. So what kinds of things cause people to get sick and die? Now, of course, these reasons for disease and death have changed drastically in the last few years. If you look at the top 10 reasons for mortality or death compared from 1900 to 2010, you see a major shift here. First of all, you see fewer deaths per 100,000. People just don't die as much as they did 120 years ago, thankfully. This current pandemic being an exception, we are seeing high levels of people dying right now during this epidemic, or pandemic rather. But in normal average years, the death rate is much lower than it was 100 years ago due to major advances in public health and medical care. You see a lot of infectious disease taking people's lives back in 1900. So things like diphtheria, heart disease, tuberculosis, pneumonia, GI infections like cholera. Almost none of these are still a major cause of death or illness today. You do see mostly non-infectious airway diseases like COPD and asthma on the list. But pneumonia or influenza now make up a very small sliver of the reasons people die in 2010. And the major cause for this huge change in public health are public works, like water sanitation and safe working conditions and modern medicine. Some things that are now more prevalent causes of disease, whereas heart disease used to be the 4th leading cause of disease, it is now number 1. Claims more lives than anything else in the developed world. And then cancers, which used to be a very small percentage of the cause of death, are now our number two. And we don't really know why that is 100%, but we believe it's because people are living longer, and the longer we live, the longer our bodies have time and chance to collect mutations. And we have a lot more exposures in our modern world to pollution and other things that we know can increase our risk for cancer. So probably multifactorial. Our diet also has changed quite a bit in the last 100 years and is not always for the better, and that we know also leads to cancer. So we primarily focus on these things when we're talking about prevention now, because vaccines and public health projects like clean water and sanitation help take care of a lot of these others. Any questions about this? Or comments? If not, we'll go ahead and move on.
Dr. Roberts, I'm curious, if someone dies of natural causes, is that under heart disease?
Typically. So yeah, most of the time when a person dies, for example, in their sleep or in like a hospice facility where they just kind of have a peaceful death, we can attribute that to cardiopulmonary collapse, meaning that their lungs and heart stopped pumping the blood and oxygenating the blood. But if a person dies of old age or natural causes, we don't always know because we don't get an autopsy. Right? We don't know the immediate cause of death. We only know the proximal cause. Maybe that person had heart failure, or maybe they had COPD, or maybe they had ischemic heart disease where their heart just didn't work quite as well. And so, it's been a hotly debated topic for a long time. Should we consider old age or natural causes as a thing to put on a death certificate? Can you really die of being old? And I think it's a question that deserves to be explored further. But we don't. It's just kind of the convention right now. I'm sorry. I hope that answered your question.
Yes, thank you.
Yeah. All right, so let's talk about evidence. As a primary care doctor, I'm a strong proponent of doing things because we have evidence and not just because that's the way things are done or because that's the way I was taught. And so we call this the evidence pyramid. You'll see at the very bottom layer of this pyramid is expert opinion. So expert opinion is what you get when you come in to talk to somebody like me and you ask them, like, what would you do or what do you think about this? And I just kind of shoot from the hip and tell you what I think based on my experience of my patients and interactions or my own personal life experience. It's helpful, it gives you some context, maybe an opinion, but it is only that. It is just expert opinion. It should not be, you shouldn't put more trust in that than what it really deserves. Above in that, we have what we call unfiltered information. So this is raw information that is gathered from studies. It is helpful. It has less bias. But again, it's still not the gold standard. The gold standard is what we call filtered information. So these things here at the top. So, high quality, evidence-based metadata that is gathered from double-blind, placebo-controlled trials that is rigorously reviewed, where the statistics are well powered and correctly evaluated. And it really does take an expert to understand a lot of these technical issues that go into these kinds of studies. But the takeaways are often done, given in terms that laymen can understand, and usually you will see something in the evening news if there's a big study that comes out that contradicts or provides new insight into the way that medicine is practiced. So in medical school, that's a big part of what we're taught is to how to critically appraise these types of studies. It's a big part of our education. And when you come to speak to a doctor, that's the expertise that you're really hoping to get is that training and how to look at things critically and how to make personalized recommendations based on that data. So, some examples of data that is obtained in these types of studies, here are some curves called ROC curves, and in these things we calculate the area under the curve and we look at trends. Here are some non-continuous data where we use things like the chi-squared analysis to look at different categories and the difference between those categories. And then you have survivalship curves using convention called the Kaplan-Meier analysis for treatments of things that are very difficult to treat, like cancer. And then you have these big forest plots where we look at multiple studies, where we're pooling, potentially tens of thousands of different data points from different studies that look at the same thing, and we're looking at the overall effect of a particular intervention on that disease process. And one here in the middle would be that there's no difference between the different, the control group or the experimental group. The lower you go in logarithmic scale, it favors the treatment, and the higher you go, it favors placebo. So whatever this thing was, you can see that most of the studies are well below this one mark, meaning that treatment is favored, and kind of this point here represents the average. So it's a lot of stuff. And so that's why I often tell my patients, please don't confuse your Google search with my medical degree. My medical degree really is a valuable tool, and I'm here to help you make sense of this crazy world. Google won't give you the same level of help. But of course, we do that. So who makes recommendations for men and people in general for preventative health? I'm going to give you some acronyms here. The first is USPSTF. So that stands for the United States Preventative Service Task Force, which is a bit of a mouthful. So this is a 15-member panel that is appointed by the Secretary of Health and Human Services, member of the President's Cabinet. And they serve on, I think, 5-year terms and rotate in and out. These are mostly family doctors like myself, research scientists, epidemiologists, whose job it is to comb through the medical literature, or the evidence-based articles that are coming out, with a fine-tooth comb, and especially those articles that deal with preventative health topics. And they collate information from those articles and make recommendations that are very easy to understand, that are based on the quality of evidence. So grade A recommendation, for example, from this group would carry very strong evidence that should be offered to your patient if they meet the right criteria. And we'll get into that a little bit later, perhaps. The WHO, the World Health Organization. Now, we've all heard about them recently because of what's going on in the world. And of course, there are other bodies, such as disease-specific councils or specific medical specialty groups, like the American Cancer Society or the American College of Cardiology. And they can often make recommendations too, based on their own studies that have been done within their group and their priorities. Of course, the American Cancer Society is going to recommend cancer screening at a younger age more frequently than perhaps a different society, because that's their issue, right? That is their nail and they are the hammer. So sometimes these groups are at odds with each other too. Sometimes, for example, there's been for the past 10 or 15 years a pretty big discrepancy when it comes to mammogram screening or prostate cancer screening between the disease-specific councils like the American Urologic Society and the USPSTF, about how often do we screen for prostate cancer, what tools do we use, and who should get screened. And so that's a good example of how, science does not always agree with itself. There are some, depending on the society that you ask. Here's the insignia for the USPSTF, WHO, the ACS, and the American College of Cardiology. So I mentioned earlier the grading system for the USPSTF on how, for a person like me who's just trying to counsel their patient in the 30 minutes we have together, what they should do as part of their checkup. So grade A is there's high certainty that if you do this for that patient, like you refer them for a colonoscopy, for example, that they're really going to benefit from that with very little harm. A grade B, which is a much bigger group, lots of recommendations in there. There's high certainty of net benefit, moderate certainty that the net benefit is substantial. A grade C is kind of a 50-50, not necessarily recommended or not recommended. It really depends on the patient and their history and their risk factors and the provider's style. A grade D, this is important. Sometimes the best thing that a doctor can do is to do nothing, is to not hurt that person. And we need to know when it's the right time to not do something. And so this grade speaks to some things that used to be very commonly performed. I'll give you an example. You know, we want to catch people who might be at risk for a stroke, right? And so you would think that if there was a test you could do that would show hardening or thickening of an artery that goes from the heart to the brain, you think maybe that puts that person at increased risk for a stroke. And so maybe you could catch those people early by doing an ultrasound of their carotid artery, that artery that goes here through the neck. And if that artery had a lot of plaque in it, then you would think logically that it would make sense to send that person for a procedure to clean that plaque out. And maybe you would help them to not have a stroke. It all makes sense. But what happened is when we actually started gathering data on people who had had that service, and we compared them to the regular population to see if they had fewer strokes, in fact, they did not. There was no significant benefit from doing that screening and sending for that service. We did not prevent enough strokes to offset the harm. And that's important for us to know because as doctors, we all promised not to hurt people first. And if we could help them, to help them. So this is where we get those guidelines, for what things are no longer, favored based on data. And the biggest category by far is the I grade, which means we don't know. There is insufficient evidence. We need more and better studies before we can say one way or the other that service makes sense for your patient on the average. So when you go in for your checkup, if your doctor is worth their salt, they will be pretty fluent in the current status of grade A, B, C, and D recommendations from this body. I look it up with my patients when they're in the room with me. I actually show them the website and we go through the grade A, B, and C and D for them personally. And then we just kind of take them one at a time. Any questions about this grading system? And then I'm going to show you kind of an example for a hypothetical patient.
Dr. Roberts, we do have a question about, you mentioned the slide before with all the different agencies and sometimes they don't always agree on the same recommendations. What source would you give people who are trying to find the latest data on coronavirus? Which sites would you recommend?
I think the CDC is definitely your go-to resource for data about the coronavirus, and your state health agency. So the state of Utah Department of Health, and depending on the county that you live in, the county medical society or Department of Health usually has more up-to-date information about where you live, and that's really important when you're talking about local outbreaks. So the Salt Lake County has a great website that is very up to date on terms of where are the outbreaks, what are the trends, and what's the level of the stay-at-home order in your county. So that's exactly where I would recommend people go. And I think those of you who might actually be working on those websites and collating that information through the county, you guys are doing God's work. Thank you. So, did that answer your question?
Yes.
Okay.
And if there's any other questions, please use the chat box and we can get those across. I'm sure that we could ask Dr. Roberts on any subject, really.
Yes, absolutely, absolutely. All right. Well, let's take the example of Cliff. So let's say I'm seeing a patient today. My patient Cliff is 56 years old. He's a white male. He quit smoking. What did I say, 5 years ago? But he had smoked for about 30 years, about a pack a day before he quit. He's overweight. He drinks maybe a little bit too much, 3 or 4 beers a night. He is sexually active, but in a stable, committed relationship, not necessarily exclusive, but stable. He's been told at a health fair, like for his employer, in the past that his blood pressure was a little high and his cholesterol was a little high, but he didn't really know what to do with that information. And so I saw a question pop up. I'll answer that in just a moment. So Cliff comes in and he wants his free annual checkup. So what do I tell Cliff? And this I think is where I'll take that question. Can you read that for me, Sandy?
Yeah, so this is referring to the grade recommendations. It asks, can you ask a doctor what grade the recommendation is coming from?
Yes, absolutely. So let's pull up this website here. So this is the Electronic Preventative Services Selector, and this is hosted by the Agency for Healthcare Research and Quality. And this is where I go to collate my recommendations for an individual patient in front of me. But you can see that these are all coming from the USPSTF. So Cliff, 56, male, tobacco user, yes. Sexually active, yes. And you go show recommendations. So here in the top green box with this header, we've got our recommended screenings, our A's and B's. And number one, if Cliff hasn't had a colonoscopy in the last 10 years, he's due. And this is recommended starting at age 50. That is going to change pretty soon in the near future to down to 45, I believe. And we recommend that currently up to age 75 on average. But you know, they're 75-year-olds and they're 75-year-olds. Some people choose to continue to screen beyond age 75 because they have an excellent life expectancy. Next on the list, we would screen him for HIV. If we determine that he was at high risk for acquiring HIV, we would talk about ways of preventing that besides condoms, of course. We would check Cliff's blood pressure. We would screen him potentially for other sexually transmitted infections such as syphilis. Farther down the list here, we also have hepatitis B, hepatitis C, but those are B recommendations. We would encourage Cliff to quit smoking, which he has. If he had not yet quit, we would offer him methods of treatment to do that. And just like that, that's all the A's. And then we would go to the B's. So the first B is aspirin. So what we would do is we would calculate Cliff's risk of having a heart attack or a stroke in the next 10 years. And if that risk was elevated based on his age, his tobacco use status, his blood pressure, his cholesterol, then we may consider him a candidate for a baby aspirin. We don't just recommend that across the board anymore. We would screen Cliff for depression. We would screen him for diabetes. We would counsel him on a healthy diet and physical activity for cardiovascular disease prevention. And like I said, if he was at high risk, we would check him for hepatitis B, C, or tuberculosis. Since he hasn't quit smoking in the, it's been less than 15 years, and he's smoked for 30 plus years, we would talk to him about a low dose CT scan of his chest to pick up an early lung cancer, which is the #1 cause of cancer in America that kills people, I should say. We would talk about how to protect himself from sexually transmitted infections. We would talk about medicines to decrease his risk, along with aspirin, of heart disease and stroke. We would counsel him on unhealthy drinking and how to cut back to a healthier amount. We would talk about drugs of abuse, and we would counsel him to lose weight, to get his BMI below 30, which is that threshold where we consider a person to be obese. So those are the A's and B's. You can see there's a lot of stuff there. So that's typically all that I have time for in an office visit, is really just to go through these A's and B's. If a person does have questions that kind of fall into the C, D, or I categories, we will spend some time on those, but I don't typically routinely go through this entire list, just because these things we don't have as much data for. And if a person comes in specifically asking me for one of those things in the D category, I try to talk them out of it, unless they have a really compelling reason to do it. So for example, Cliff, with no history of testicular issues or no history in his family of testicular cancer, if he asked me to send him for an ultrasound of his testicles just to make sure that he doesn't have testicular cancer, I'd probably encourage him not to do that. The same would go for thyroid cancer, pancreatic cancer, COPD. Unless he had symptoms or really concerning findings on exam that increased my suspicion for those things, I would not send him for these studies, because the chance of a false positive leading to unnecessary treatments and potential harm outweighs the benefit. So this is a very helpful resource. This is my go-to when I'm doing a preventative health checkup with my patients. So that's what I would counsel Cliff. And so based on his risk factors, I would recommend the following: colon cancer, HIV and Hep C screening, blood pressure, alcohol misuse. I would calculate his need for aspirin and statins, screening for depression, checking for diabetes, talking about healthy living and lifestyle, lung cancer, obesity, and STD prevention. That's what Cliff would get from me. And, time permitting, we might go into those other categories. But I'm young and healthy, doctor. Do I need to see you? So some other things that I could talk to a younger person who's not maybe as unhealthy as Cliff would be things like diet, exercise, sleep, and sex life, how to protect themselves from unnecessary risk, their mood, social support, family history. We talk about the goals of care. What do you see yourself doing in 10 years? How can I help you get there? And especially right now when we're in the midst of a global pandemic and a lot of people are faced with these really harrowing end-of-life decisions, having a discussion about what kinds of resuscitation, what kinds of life support you would want, if God forbid, if you found yourself in that kind of a position where you were in the ICU, potentially looking at weeks on a ventilator or on artificial nutrition. Is that something you would want? Is there a certain cutoff? If you had less than a certain percentage chance of making a successful recovery, where you would want the medical team taking care of you to withdraw that care and kind of make you comfortable and gather your family so you could have a dignified and peaceful death. Now, those are hard conversations, but so important to have, especially as we get older and that becomes more of a realistic, near-term thing that we might be facing. These are all very appropriate things to talk about during the annual checkup. So, the last point I'll mention here is, I'm sure many of you have heard this analogy between the fence and the ambulance. Where should we invest our time? Should we put, an ambulance down here at the bottom of Bryce Canyon and just leave the top open here for people to peer over and fall if they want to? It's free country after all. Or should we put a nice strong fence up here? And I'm personally of the opinion that a fence is better than an ambulance, and so prevention is better than cure. Catching things early is definitely better than mopping up the problems later. And so having a checkup with your doctor is definitely worth the time and the money. So my top 10 preventative health tips that I would give to any patient coming in to see me. Number one would be get your shots. Don't be an exception. They're recommended for a reason. They are the number one reason why people don't die of infectious disease in our modern age. Number two would be control your blood pressure and cholesterol and use medicine to do that if you have to. Number three, stop smoking. There's no safe amount of tobacco use. Alcohol and caffeine are okay and can be okay in limited amounts. Number four, eat as many fruits and vegetables as you can stand. Number five, exercise as much as you can without overexerting yourself or hurting yourself. You don't want to take stupid risks. I'm jumping ahead, sorry. Number six, wear sunscreen while you get plenty of sunshine. Vitamin D is important, but you don't want to get skin cancer either. Number seven, improve your sleep hygiene and get plenty of rest. It's almost impossible to overstate how important good sleep is to your health. Number eight, reduce stress and increase conscious action through mindfulness. This is a really in vogue topic in health right now, but it really has a lot of good data. And people who have some sort of mindfulness practice live longer, have less disease, and less stress. Number nine, find somebody to love safely and responsibly. And that's a very important, vital part of being a healthy human being. And number 10, don't take stupid risks. If you want to live a long life, then you need to be a risk-averse person. So with that, I will open it up for any questions that are out there. And thank you so much for your time.
Thank you, Dr. Roberts. And we do have a question. It says, are you seeing more food allergies, gluten, et cetera, than in the past, or just more awareness and diagnosis?
That's a really good question. I personally have not been seeing a lot of true food allergies. I've seen a fair number, not above more than I would expect. But I definitely think that awareness is becoming more of an issue. I think we're always looking for reasons to to say, I just feel tired and fatigued and feel like I get sick more often than I should, and it's got to be what I eat, right? I mean, and it makes sense. What we eat it plays such an important role in our health, and so it's a very it makes a lot of sense that a person would kind of go to that to think maybe it's my diet, maybe it's something I need to change or cut out, and I'll feel better. But I just have not seen the data support that gluten or lactose or eggs or some of those other really common things, that there's enough of an incidence out there, or enough of a prevalence, I should say, to explain a lot of the symptoms that are often attributed to that. If a person does think that they might have a food sensitivity, the first thing I would do is say, try cutting that out of your diet for a few weeks or a month and see if you feel better. And if you do, great, you have your answer. There's no need for fancy, expensive testing. But if a person, but I don't want to say too that there's no such thing as gluten allergy. There absolutely is. And so it depends on the severity. So if a person's life, if your ability to enjoy your life is dramatically affected, diarrhea is so severe that you can't function, you should definitely go get that checked out. So good question.
And then we have a request for some vaccine resources that you mentioned. If you're able to send that, and I can put that on our website.
So the vaccine resources. So I have a presentation that I'm more than happy to share a link to. But so a good resource for what vaccines are recommended. If it's a child or an adult, or if they have special scenario like a person without a spleen, there are specific vaccines that are needed in that case. I would point people to the CDC's website for the vaccine schedule. And there are also some really great apps that you can download on your phone from the CDC to go through, what vaccines are recommended at what stage of life, and to who and how often. And of course, your physician is a good resource for that as well.
Very cool. And the next question is, do you see a difference between those who consume the traditional American diet and those who are vegan or vegetarian? If so, do you attribute that to just eating more produce or to eating meat, sugar, or preservatives?
That's a really, really good question. And I think that the traditional American diet is not a good one. We far too many highly processed foods that are lacking in fiber, that are excessively have heavy amounts of preservatives that contain salt and other products, that do not give us the minerals and nutrients that we need and the vitamins that we need. And so in general, I recommend that people, I don't necessarily think that we all need to become vegetarian or vegan. In fact, there are some important nutrients that come in animal protein that are difficult for vegetarians and vegans to get without supplementation of multivitamins and things. But I do think that most of us could benefit from eating more fruits and vegetables. What we recommend on an average daily basis is 5 servings. And a serving is probably more than most people realize. It's about what goes in the cup of your hand. So, a cup of cooked carrots or broccoli, cluster of grapes, a half an apple or orange. That's 1 serving. So if you're thinking 4 to 5 servings a day, it's like 4 or 5 handfuls. And salad is an exception. Two cupped hands together is 1 serving of salad because it's so loosely packed. So we could all, I think, benefit from more fruits and vegetables in our diet. And I think that's a good place to start if you're thinking about improving your diet.
Excellent. And the next question is, how do I get my husband to take his health seriously and get the required screenings and an annual wellness visit?
Well, the first thing I would say is, when I have a person come in for their annual wellness, I try to send them home with an after visit summary. So kind of a written prescription, if you will, for all the things I recommend over the next year. And I would say, if your partner comes home empty-handed, then call the office and ask for one of those to be emailed to you or something like that, so that you know kind of what was discussed, what was the plan. And you can, create a series of events in your calendar to make sure that those things get done over the next year. The devil's in the details, right? I can talk to them blue in the face, but if you don't leave my office with a plan of how you're going to attack those things, it's probably not going to get done. So make sure when you leave your checkup that you leave with that after visit summary that has the plan spelled out, because who's going to remember my memory is not the best. I often forget what was said in a conversation within a minute or two. And that's just normal. That's being human. So get it in writing is the first thing I would say. And then, just make goals. Just pick one or two of the things that you discussed with your doctor about how to improve your diet or lifestyle, and really focus on those one or two things. You don't need to do it all. It's not an all or nothing scenario, especially if you have an ongoing relationship where you're going to revisit those topics every year.
And the last question we have is, could you identify 5 foods a pre-diabetic should eliminate from their diet and 5 that they can eat that would help them in controlling their blood sugar?
That is a great question. And then let's make this our last question for the day. So number one food or drink that should be eliminated if a person is pre-diabetic is soda. And I'm talking about all forms of it. So the regular and the sugar-free. That's got to go. And with that should go all sugary drinks. You really don't want to drink your food. You want to eat it. And soda, I think we will find in the future, is one of the number one, if not top 5 contributors to our obesity and diabetes epidemics in this country and in the developed world. So if I had to pick numbers 2 through 4, they would all be refined starches or refined sugars. So things like white bread, white pasta, white rice, white potatoes, and dessert foods. You absolutely can have those, and most of us get most of our calories from those sources in a post-agricultural world. But we really should be focusing more on the whole grain options. So the whole wheat bread, the brown rice. If you have potatoes, keeping the skins on, going for the yams and sweet potatoes rather than the white. And dessert foods really should not be doing a thing. They should be a special occasion thing. As little as possible. So I'd say those are the top 5 to try to cut out. The ones you want to increase are your lean proteins and your high fiber foods. Those are going to keep you full. Those are going to level and stabilize your blood sugar. Those are going to help keep your poops off, right? And that's important. Having a regular bowel habit is a very important part of your health. And so I'd say, lean proteins, especially vegetable kind of proteins, legumes, and nuts. Of course, also your eggs and your dairy products, your chicken, your fish, your red meat once in a while. And yeah, I think that's where I would start.
Well, thank you so much for your time, Dr. Roberts, and everybody who joined us today. And I hope to have another workshop with you. It sounds like vaccines would be something that people are interested in.
Absolutely, it would be an honor. Thank you so much for the invitation, and thank you all for your participation. It's a little strange to do it in this way, but I'm glad we're all being safe and keeping our distance.
Yes, thank you. And we'll see you next time.
All right, bye-bye.